I won't dwell on who I am. We know what we're aiming for. We're aiming to eliminate hepatitis C, and the targets we're aiming for are by 2025 to eliminate it in the UK. We know that people who inject drugs account for 95% of all new diagnoses. One thing that we also need to be clear about is that people who inject drugs are a heterogeneous population. They can circle in and out of this group. But what I'd like you to focus on is we are focusing on people who are in drug and alcohol rehab services and prisons, and whilst it's not perfect, they have a pathway into treatment. But there's another group. There's a group who don't engage with that. They dip in and out. They may also have no fixed abode. They've got no GP, and they have no NHS number. So to prescribe them treatment, you need an NHS number. The other thing is they don't engage on a regular basis with healthcare services. It's very sporadic use, but where they do engage is with the needle exchange services and in the community pharmacy, and that's on a regular basis. So why don't we harness that relationship with it, which exists, to get treatment to these patients? So this was where this project all developed, and it was to have the objective to develop a sustainable, effective point-of-care testing for hepatitis C into supported pathways for people who are actively injecting drugs, because they're at highest risk of acquisition and transmission, and but the people who only are sporadically engaging with healthcare services. We also wanted to determine the prevalence of hepatitis C in this group. They're not registered on many public health surveys because they don't have a GP number. They don't have an NHS number. They may have an alias. So this was also one of our objectives, and also to utilise the relationship that we know exists to see if we could get testing for them and then access into treatment. We also wanted to educate them on new treatments that are available that don't involve interferon, and also on safer injecting practices. It's not just about hepatitis C, it's also protecting them to prevent them getting reinfection. We engaged with a huge number of partners, and it extended, and I'll leave you to read all of that, but it extended from the community pharmacies all the way up to commissioners. We also had to have data collection, so with sonar and pharma outcomes, but also with the operating delivery networks and with Invitec and MSD in pharma to make it happen. Now, London, as we know, there are many boroughs. So where do you start? Well, let's take a pragmatic view. There's a river running through the middle of London, and so let's split our pharmacies north and south of the river. It makes it easier. And what we did was we chose our pharmacies on the basis of information from the local pharmaceutical committees and the local commissioners on the level of needle exchanges in those pharmacies. We also looked at their implementation of healthcare improvement initiatives that had been put forward, and they needed to fulfil our service operating procedure that we developed. And essentially, what we developed was to not just a service specification, we also had to build the partnerships in order to get the pathways created directly into treatment at the ODN. So a big ask, but it's possible. And all of our participating needle exchange pharmacies had to fulfill certain criteria, because we wanted the same governance structures that we provide treatment for and testing for our patients in hospital to be provided to these patients. And they had, for example, they had to be adequate facilities to have a confidential discussion. You had to have successfully completed the Royal College of GP online hepatitis C module, so that the pharmacists had the knowledge base to advise patients. We organised with the Hepatitis C Trust a evening programme for training on how to do these discussions for testing and how to do the discussions when they're positive, how to offer treatment. So what's the right approach to take? And they were enjoyed by the pharmacists, but also they were very helpful to the pharmacists, and we enjoyed doing them. We also made sure that post-pilot there was a project meeting so that we could discuss what things went well, what things didn't go so well, so we could move on to the next phase. And then we wanted to accurately have all the data captured, so we had to develop those referral forms, but also how we would develop that in the future to make it a much more sustainable project and something that could be done nationwide. We also had to have some pathway, as I said, for the referral, but also if patients were tested negative, their GPs, if they agreed, could be then informed to be retested in 6 months. And also to those people who didn't collect their results of their hepatitis C testing, we needed to have their permission to let their GPs know. So all of that was integrated into a pathway. Now, there are many obstacles. We didn't have the relationships, but we built them. There was concerns within, and they're legitimate, if you don't know much about hepatitis C, about acquisition. We allayed them. If you have no NHS number, we worked out strategies on how you could get those, whether it was a GP locally who would be happy to, near the pharmacist, to provide that, whether it was through a sexual health clinic, or whether it was done directly through the hospital. And we also became aware that people were using aliases and nicknames. So we just asked that people were asked what their birth name was. And that was put on the referral form, made it easier to find them. And some of them already had GP numbers and NHS numbers. And what do you do when you've got no fix about? It's all very well creating a pathway to an ODN, and the ODN sends you a letter to say, come for an appointment. Well, where's that going to go? So what we did was we worked with the pharmacist to say, well, how about you act as their mailing address if the patients agree? So then they could pick them up on a regular basis, and both the pharmacist knew, and they could also remind them, you know, you've got an appointment at this time. So these are the results. So essentially, it's young people who are affected by hepatitis C, and they're ranging from the 30s to the 50s. And a lot of people have already been tested previously, but never engaged in treatment. And you can have a look at those diagrams. They've been tested in various places, including drug and alcohol services previously. So this was just to give you an idea of how we did it. So in the first phase, we used oral swabs. And the patient came in, they were offered the test. If they accepted, they had it done. Then they were waited for the test result within an hour and a half. And they were given a voucher to pick up, a £5 contingency food voucher to pick up their result. And then they were then advised on whether they were positive or negative, had the discussions, and then linked into care. Now, what you can see is we went with the aim of 200, but some of them were not quite right. And so we ended up with 178 patients in total, because the wrong patients had been tested. Of those, 93% were antibody positive. All that means is that they've had exposure to treatment, to hepatitis C in the past. And then things start to wane off. When you're referring them to the ODNs, to the hospitals, the numbers start to drift. So the key findings, and I'll just go through them, is with the antibody testing, as I said, 53%, so 93 service users were found to be hepatitis C positive. 41 service users were found to be hepatitis C positive for the first time, antibody positive for the first time. And we found that there was weak evidence that if you'd never been tested, you were more likely to be hepatitis C antibody positive. Then the referral onto the ODN, well, only 23 of the service users attended their first appointment. And then of those, 78% were found to be hepatitis C RNA positive. 33%, so 6 service users, were found to have cirrhosis, which is a concern. And 16 service users were approved for treatment, 15 started treatment and carried on. Now, service user feedback showed that 57 of them had been tested previously, did not know that treatment now was interferon-free. And what's striking to me is 84% of them would be happy to engage with treatment in the community pharmacies. And that's what we need to strive for. And that's just showing this in a more graphical sense to you. So the conclusions are that we know that opportunistic hepatitis C testing in NSP community pharmacies is effective, and it can identify PWIDs who are not engaging in healthcare services quite easily. We saw that there was a high uptake of testing and re-engagement of those who had been lost to follow-up previously. And so it makes it an attractive testing as part of a national hepatitis C elimination strategy. And engagement into secondary care is what we need to work on, because it was poor despite the provision of providing trained peers. And we need to provide education on direct-acting antivirals within this community, because there are misconceptions, and we're working on an awareness campaign with Yvonne's support. Also, there's other healthcare that was provided to these patients during this time, and they were given the flu vaccination because it was done during the... So you can do other things as well as the hepatitis C testing. So what we're doing now is phase 2, and now we're using direct testing of for viral RNA in these patients, so we can tell them directly within an hour whether they have hepatitis C or not. We have updated our services, so we've now got a computerized system for the pharmacists, so they're not using paper referral forms, and we're linking in with NHS Digital and Sonar to make it into a more robust platform. We've also worked with MSD and created a model so that we've moved this now into Birmingham and Manchester, so that we're comparing whether this can work in a larger other cities in the UK, and we're comparing peer support versus contingency voucher and secondary care appointment. So I'm just going to give you some preliminary results, so I won't dwell on the pathway. But essentially, what we're finding is that 24% of the patients tested in London were hepatitis C RNA positive. In Birmingham, it was 20%. And problems, even though Birmingham are offering a contingency voucher for patients to attend their first appointment in the ODN for treatment, what they're finding is it's still difficult. They don't attend their second appointment. So this is something that we need to work on. And so for our future, we go on about a patient-centred approach. That has to be in the pharmacy setting. We're working on with Public Health England for epidemiology to get more information about these patients. We want to record this information, so we're creating this platform. But we're also creating this testing and awareness, and we've got permission from and engagement from commissioners in all of the boroughs where we've been working. So we're now providing a leaflet inside the needle pack to give patients information that interferon is no longer required, and we're going to be working with Yvonne to try and make this across London. And one of the straplines could be new hepatitis C cure, no interferon injections anymore. And then we want to try and push harder to get the DAA treatment delivered directly in the pharmacy and overcome these barriers which should be surmountable, but I'll leave Graham to work on that, so that we can give the treatment as we have akin to methadone. And there are loads of people to acknowledge, the pharmacies particularly, but everybody involved, and we've had engagement for Steve Bryan. Bottom picture is not the Spice Girls tour. It is a PMA award that was given to us for highly commended for this project for all of the people who have worked tirelessly to make it a success. Thank you very much.